everyone. Also, we have a special occasion, just like 1 year for our crime club. It was in June 2023, so now 1 year. I wish everyone was here to celebrate. Just to be very brief, we have today 4 talks. One will be led by JULPHAR and 3 other talks. I will introduce our first speaker, Dr. Nahar Baroudi. Dr. Nahar Baroudi is consultant endocrinologist at Parkview Hospital here in Dubai. She's a Swedish board of endocrinology. She have a very nice, challenging case of hypertriglyceridemia. So the floor is yours, Dr. Nahar.
Thank you. So, good evening, everybody, and thank you very much for giving me the opportunity to be among you today and to get your input and to present my challenging case of hypertriglyceridemia. So, this young lady, 28 years old, female medical student, was referred to me for hypertriglyceridemia in January 2024. The triglycerides level were around 30 millimole. And if we go back to the classification of triglyceridemia on severity, we can see that the normal range is below 1.7 millimole. Moderate hypertriglyceridemia is 1.7 to 5.6. Moderate to severe is 6.5 to 11, and severe hypertriglyceridemia is more than 11 millimole per liter, and this lady had 30 millimole per liter. And she was diagnosed with familial hypertriglyceridemia at the age of 4 years old. At that age, she presented with acute pancreatitis. She had another attack of acute pancreatitis in year 2020. Her past medical history, she had fatty liver, polycystic ovary, and she had family history of ischemic heart disease, but she did not have any significant history of family history of hypertriglyceridemia. On examination, her BMI was 20. She had no sarcomas or xanthelasmas, and she had normal blood pressure. And our findings, I was able to review her lab since 2019, and the triglycerides were always ranging between 20 to 30. The LDL was not elevated. She was not diabetic. Her HbA1c was 5.5. Her thyroid, she had normal liver function test and normal thyroid function test. The fasting insulin was adaptable, 15, but it's pointing towards some kind of insulin resistance. So I ran out further investigations, and she had elevated lipoprotein C, 11, and the upper range is 6.3. Of course, also elevated apolipoprotein B, 1.88, and the upper range is 1.28. I was desperate at that point to find any reason behind this severe hypertriglyceridemia, so I even ran 1 milligram dexamethasone suppression test, and she suppressed perfectly. She had already started treatment with fenofibrate since 2013. According to her, she was compliant with her medication. Despite that, when I reviewed the lab throughout the years, there was no improvement. The range was 20 to 30. She was not overweight, and she was a decent medical student, a non-smoker, non-drinker, exercising regularly, low fat and carbohydrates intake. And she was on fenofibrates, rosuvastatin, and omega-3 fatty acids, 1,000 milligrams twice a day. At that point, I was standing and thinking, what shall I do? Shall I admit this girl and give her an insulin infusion? but at the same time, I need a permanent solution. Like she received insulin infusion before, improved, and relapsed again. Shall I increase the statin, intensify the statin treatment, or increase the dose of omega-3 fatty acid, or try icosapent ethyl, or add PCSK9 inhibitor? Now, thinking about that, I mean, we have also a risk of atrial fibrillation. We have the risk of hepatotoxicity, muscle toxicity. Yeah. And what is our treatment goal? Of course, my biggest fear was to have another attack of pancreatitis. Of course, it will end up with pancreatic failure and severe complications, and she was only 28 years old. The other target was to reduce the cardiovascular risk. And at this point, what shall we do? Shall we target the triglyceride level, the LDL level? The LDL was not so elevated. Okay, here is the short summary about the effect of lipid-lowering drugs on serum lipids. So, if we see here, fenofibrate, we can expect reduction in triglycerides up to 53% depending on the baseline of the triglyceride level. Gemfibrozil, 50% reduction at the maximum. Nicotinic acid is not available. Marine omega-3 fatty acid, we can reach up to 45% risk reduction. PCSK9 inhibitors, 23%. Statins, 33%. At that point, she had tried the icosapent ethyl, and she was reluctant to try it again because it was very expensive. And she tried to increase the risk of omega-3 fatty acid up to maximum dose 4 milligrams per day. We tried to intensify her statin. We tried another fenofibrate, another fibrate, gemfibrozil, but the maximum we could reach triglyceride of 23 millimoles per liter. Okay, so again, our main target was to reduce the risk of acute pancreatitis. So we know that fenofibrates can reduce the risk of can reduce the level of triglyceride significantly, but we don't have enough data showing that fibrates can reduce the risk of pancreatitis. On the other hand, statins generally have mild to moderate triglyceride lowering effect. There is some evidence that statins may help lowering the risk of pancreatitis, although evidence is lacking in patients with moderate to severe hypertriglyceridemia. So we don't have really an effective drug to reduce the risk of acute pancreatitis in this case. So what was my final decision? I sent her for plasmapheresis. The decision was easy. It was easy to take the decision to send her for plasmapheresis at this point. But the challenge was to find the facility that can offer this treatment. So I would like to hear some input. What would you do, or what would you suggest? What was missing? What do you think I should have done?
Any idea?
Would
She
you
never
admit
had
that?
plasma, so you said in the past.
Sorry?
She never had plasma.
No. I had to call so many hospitals and hematologists and nephrologists and trying to find in Abu Dhabi and in Dubai and in government hospitals. But at the end, I found one place. Yeah, but what would you do? Would you admit her for IV insulin? She did not have pancreatitis at that point. What did you started lowering with IV insulin, and then
I had one patient that he had pancreatitis and
Yeah.
also had diabetes which was not detected. So once the blood glucose got controlled, and he also had another episode of pancreatitis, which at that time incidentally nobody evaluated him for, nobody checked his even TG levels. Once his blood glucose got controlled, he improved a lot after
yes,
that.
yes, because he had a secondary cause, but this is obviously the lipoprotein.
So
He
he
was
admitted
irritated.
and we gave him infusions and he responded very well.
Yes, yes, yes.
But I think this patient is not diabetic, right, Dr. Nar?
She's not
You
diabetic.
always in diabetic patient when we make tightly control A1C, secondary hypertension blood control. But the problem she's familiar for 4 years, right? Started
Yeah, 4 years she had a first attack.
first attack. So this is familiar hypertriglyceridemia,
Exactly.
right?
The other thing is we also admitted patients and kept them on strict NPO diet for 48 hours before we try any of these, treatments. Because when you absolutely starve them, their levels do come down, their risk does come down.
Very low.
If it, either very low calorie or just strictly NPO for 48 hours before you try any other treatment, just to get them, kind of prepped up. This is again patients who are not diabetic, not on insulin. But also, I don't know, we can actually try insulin even for non-diabetic patients.
But
So,
what happens
Temptation,
is
the long term is a problem. Temptation is admit, treat, but we can get it in few days.
exactly.
But what's the long term?
What's the
Maintenance,
long term?
what
It's
have
an
we-
acute setting.
Yeah.
I will not use insulin infusion unless outside the context of acute pancreatitis. Because this, as Dr. Ali, this is for acute event only, but what's the long term?
She
And even
she
plasma
was-
freeze, what durability is this?
Exactly, because she had pancreatitis, she received IV insulin, she improved, but she relapsed. And if I would combine all this treatment, like intensify statins, fenofibrate, give her a high dose of marine omega-3 fatty acid, there is a risk of hepatotoxicity, risk of atrial fibrillation, very high. There is a risk of muscle toxicity.
was she
But-
taking anything chronically?
Yes, yes, yes. She was taking fenofibrate, but rosuvastatin 10 milligram and omega-3 2000 milligram. But we were able to, we tried different approach.
But why gemfibrozil?
I
You know,
was-
combination with the statin can increase the risk of
Exactly, but I was desperate, yes. I
Yeah,
was,
just try
was trying.
You know, I think what you can do.
I have
Maximum dose fenofibrate,
phenofibrate.
maximum of omega-3 fatty acid, like for up to 4 tablets as we do for the patient.
Yeah.
Statin, high intensity statin if tolerated. Maybe PCS canine inhibitor, but I don't know under any insurance will cover this.
Yeah,
And you feel it's
and-
only control.
The-
Like I said, minimum, 5 to
The
10%.
Very low fat diet.
So, as doctor say, maybe Rofaden, and maybe my target just to keep it less than 500.
Yeah.
Not
Yeah, but-
normal, to reduce the risk of cardiovascular or pancreatic, maybe.
exactly.
And I
But
think there is new
from
medication.
30,000 to 500 was, you mean from 30,000
Yeah, so
to 11 millimole, because we're speaking here about millimoles. So from 30,000 30 millimole.
yeah. It is like
It
30,
should
it
go
is like
to
3
6 millimoles to reach 500. If I'm not wrong, right? No,
Yeah.
must be.
Yes,
Five,
yes, yes.
5 to 6 is
Yeah.
500.
Anyway,
Dr. Nar, there is one drug, but I don't remember the name. There is one monthly injection for hypertriglyceridemia. I think they take EMA approval, but don't take FDA approval.
exactly.
I don't
I will
remember
come
the
to
name.
that.
Mm.
So now, after sending her to plasmapheresis, she is keeping the
How
triglycerides.
frequently, which facility are you going
You want to know the name of the facility?
to? Also because it's needed.
That was a talk. No promotion.
How frequently you did?
Nice.
I don't know actually, because I referred her to another colleague where he had this this very unexpected facility. But he was able to maintain it around 500, but I don't know how long the insurance will approve that. That is the issue. And we have some emerging therapies for hypertriglyceridemia, we have the monoclonal antibodies, gene therapy, but the most promising is what you mentioned, Dr. Shihab, is the apolipoprotein C3 inhibitor, which inhibit lipoprotein lipase, but it's approved in Europe for monogenic chylomicronemia, and it was able to reduce the triglyceride level to 750 milligram per deciliter in 77% of the patients at 3 months. But this is still under trial and it is not approved. So basically, we just wait for this drug to come and maybe we can have more facilities with plasmapheresis for this kind of cases.
But like weight reduction and this.
She was 20, she was thin.
So there's no component of secondary, it's just.
Exactly. She was, her BMI was 20.
So this drug reduces ApoC, and what she has is elevated ApoE and ApoC.
Yes, this is for monogenic, but like there are different genetic mutations for hypertriglyceridemia. So it was just working for monogenic chylomicronemia. I did not go through it in this slide the genetic disorders, like the different mutations. So in some mutations, by allelic mutation, it was not working, this medication.
So our patient had elevated ApoE and ApoC.
B. Yeah. E, apolipoprotein E, it was elevated, and B.
And you can easily test for those. You send them to us.
I was able to test them, yes. I was able to test them easily.
Any further question before we go for our second speaker? A case of familial hypertriglyceridemia. Interesting.
Okay, thank you very much.
Any question online? No question online? All right. So we go for our second speaker, Dr. Alshana, a consultant endocrinologist, Taqi University Hospital. She have a very interesting topics. Myxedema coma. We seldom see nowadays myxedema coma, so it's very interesting.
Hello, everybody. Like Dr. Anat mentioned, myxedema coma is very rare. So obviously, when you have a case, you get excited. And this was a kind of a unique case because he had a lot of comorbidities. So I think that's why it makes it interesting. So this is a 48-year-old male. He was actually brought to the ER by his roommates. And the only presenting complaint was for the last 48 hours, he was weak. He had complained of some abdominal discomfort. Later, when we spoke to the patient, he said he had some, abdominal pain. He went to a local pharmacy and they gave him ibuprofen, and he thinks the ibuprofen caused all of this. Anyway, so this was and this for the chronology of events. This was on presentation in the 4 a.m. on 19th, and so in the ER, his heart rate was 44. His blood pressure is 90/45. He was hypoxic. His GCS initially was 12, kept getting worse to 3, and he was obviously initially sweaty, pale. Temperature was not bad, 37. His random sugar was 400, and his weight for other purposes. So obviously this is in the ER. So immediately the cath lab was activated. He was intubated, atropine, dopamine given, pressors and IV fluids, IV insulin because the sugar was high. His EKG showed basically complete heart flow. There was no obvious ST elevation. So after getting his heart rate to about 62, after stabilizing, there was just possible. So the initial, based on the heart rate of 44, what is the first thing that anybody thinks about? The patient in the ER, the bradycardia. The obvious thing is, whether this is MI. So A patient immediately within 90 minutes had a coronary, angiogram which showed triple vessel disease, and obviously severe hypokinesis, EF of 35%. The only thing we knew at this point of time, he was a laborer, no family, he was from Pakistan. He had past medical history of diabetes, asthma, and hypertension, but he was not taking any medications. And he's been here for a few years. Um, I just, sorry, yeah, okay. So this is his lab. This is again on presentation in the ER. So if you see that, he's acidotic, 7.2, not bad. Mild hyponatremia, bicarb is 15. Some mild AKI. His GFR was 50. He had some, elevated liver enzymes. PTINR was compromised. He had elevated D-dimer, elevated troponins. His CKMB was normal. Initially, so the cardiology team, decided this triple vessel disease, but delayed MI presentation. So no PCI was done, and he was just, put on the standard medication for MI. Continued to be intubated, pressors taken to the ICU, tube feeds. This is from the ER. So he presented at 4 in the morning, and after a few hours, then finally the thyroid was done. TSH was 57 with a significantly low free T4 as well as free T3. So at this point of time, they didn't decide to call the endocrine team. They just gave him a dose of 50 micrograms of Thyrox. So this is few hours after presentation, and he had an NG tube. He was intubated. So they quickly extubated him actually within 24 hours. Again, we were not called at that point of time. He was extubated, though he was severely, lethargic or conduct. So, his initial, when he came in, he was obviously bradycardic and hypotensive. So after they stabilized him and they realized that, he's hemodynamically better and we just need to do medical management, they decided to extubate him. So when they extubated him, besides his mental status, everything else was good. His blood pressure, his heart rate is all good. Again, they gave him, the next day they gave him 50 micrograms via the NG tube. And at this point in time, he was extubated, and so he threw up, so that even that 50 micrograms really did not go in. And at this point of time, I was consulted. At this point of time, I had a TSH, I had a elevated TSH, low free T4. He never had any history of hypothyroidism, diabetic hypertension, this was, and he had an MI. This was the only, data I had. So, can anyone think of the first step? What would we do when we have this kind of situation? In terms of assessment, how would you first assess this patient?
So, is this any other information or is this all information?
This is the initial. So, I want to talk about the first thing. When you're called as a consultant, this is the patient in ICU and who's had an MI, who's had a significantly low free T4. What's the first thing you do before you decide to treat this patient? What would help your treatment?
Myself, I will check serum cortisol as well. And it is primary hypothyroidism. So I will start treatment the way you do in a low dose as a patient, I think ischemic heart disease, right?
Yes.
So,
but before that, how would you, come to a diagnosis? So we see a lot of hypothyroidism, but how would you know this is severe hypothyroidism? So that's where, my talk comes in too. So basically, the first thing you do in this situation to see whether this meets criteria for mixed edema coma. So this is where you get the scoring. The scoring is the most important thing because, mixed edema coma puts your mortality right up there. So if you're called in this ICU, the first thing they expect you to tell them that how severe this is. So this is very, very important. This is called the Wojtowski score. And the scoring is based on all preliminary data you have. So for our patients, somehow this pointer is not working. So the first thing is temperature. So his temperature is 37, so that's 0. Then in terms of central nervous system, So he was somewhere between of thunder and stupor, so that would give him 15 to 20 points. He had GI findings because he had abdominal pain before. He had an NG tube, he was throwing up, so he probably had ileus. Precipitating event, again, there was nothing clear and obvious at that point of time. So we don't know, what started, the cardiovascular or, the hypothyroidism. Of course, his based on his heart rate, it was 44, so that gives him 20 points. That's between 40 to 49. He had other EKG changes because he had an MI. He had pulmonary edema. He was hypoxic, intubated. He was hypotensive. Metabolically, we said he had low sodium. He was hyperglycemic, not hypo. He was hypoxic, hypocapnic. He had decrease in GFR. So clearly, he was the classical mixed edema coma. So if you see, if this is less than 25, it's unlikely. 25 to 60 is suggestive, and greater than 60 is highly suggestive. So this is the most important piece of information. A patient calls you, when the ICU calls you. So this was clear-cut mixed edema coma. So your antennas definitely go up. So so clearly, 50 micrograms of euthyrox given to him over the past 24, 48 hours. The first thing we want to do is, like you said, we want to give cortisol. Now, the issue in this case was cardiology was very reluctant to give steroids because they said somebody with an acute MI with a low EF, giving steroids put them at risk of tamponade. So they were very, very reluctant in doing that. So of course we got a random cortisol level, and someone who's so severely, sick, a cortisol of greater than 40 is amazing level. So we said yes, we can do without steroids. So cardiology was very happy. Otherwise, we talk about the management. It's very important to start with steroids because when someone is hypothyroid, you're giving them thyroid medication, you're going to increase the metabolism. So whatever endogenous cortisol you have, you're going to probably clear it faster, unmasking any kind of adrenal insufficiency. So it's very, very important. So at this point of time, at the hospital, we have this patient. We don't have any access to IV levothyroxine. So it's only a patient with NG tube and who's sick. The immediate option when I was trying to get hold of any places in Dubai with IV, levothyroxine, we had to start and give him something. So I gave him 250 micrograms, and I'll talk about why I chose that. Why NG tube? He had already received 50. We don't know if he threw that up that morning, so I gave him 250. And that day he was extubated, pressures were weaned off. His sugars were getting better with the insulin. So 19th he was admitted. So day 3, though he was extubated and vitals were stable, but his mental status had no improvement. He was very drowsy. He was agitated. They were actually requiring to give him Seroquel and Haldol because he was pulling off everything. And we continued to give him 250 micrograms Ng. We'll talk about what the levels of the thyroid T4 were. After that, so initially after being extubated, though he was doing better, but when they were doing daily labs in the ICU, they, said some of the parameters were getting worse. So, for example, his creatinine was getting worse. His liver enzymes, you can see from 300 it went to 3,000. So obviously, we thought that he's not perfusing well, and he cannot have any kind of PCI. It was medical management. So cardiology team was, concerned about him. They put in a central venous catheter to monitor. They started him back on pressors. And luckily, at the same time, we did get access to IV euthyrox at this point of time. So we got it from another facility, and it was great timing. So we started him on a dose of 150 micrograms. So this is again showing worsening LFTs, worsening CRP. At this point of time, when we did the free T4, so from an admitting value of 0.1, it had improved to 0.6. This is even before IV was started, IV euthyrox. And then, so cardiology was doing diuresis, inotropic support, just basically to get, him perfusing better. Over the next few days, we continued the same dose of the IV, the 150 micrograms. And he kept getting better because he was getting the pressors and all of that. His creatinine kept getting better. His mental status kept getting better. Uh, to be noted is when I did the free T4 on 24th May, it was actually done after the dose in the morning. So it was zero point 0.6, it looked great. Then I said, hey, let's get a free T4 in the morning before his morning dose, whether IV or oral, and that came back as 0.49. So at this point of time, we decided that, so actually the IV levothyroxine ampoules are 200 micrograms each. So if you're doing anything less, you're actually wasting the remaining drug because they throw it out. And these are very expensive vials. So each vial, I think, is a couple of, thousand dirhams. So we didn't want to waste. So we said, okay, let's give the full ampule. Anyways, his PT4 at this point of time was getting better, but not optimal. So for the next few days, we just gave them, full ampules. So again, so 19th was presentation. So this is up to 28th May. He finally was getting better. Everything was getting better. So this is the main, slide where I have compared the doses, the route, and the levels of the 3T4. So when he came he came on the 19th, and he started getting the euthyrox on the 20th. We started the team, admitting team, gave him 50 on day one. And day two is when we got involved, and we started giving him oral, via NG, of course, the first 2 days. So if you see, again, I can't point this correctly. So if you see on top, the free T4, so he was admitted with a level of 0.127, and from 20th to 22nd May, just on oral via NG, so we don't even know how much he's absorbing. He has ileus, he's been throwing up. Even what he absorbed, the 200 microgram, it did jump up to 0.632. So we started IV only on 23rd. So if you see on top, on 24th May onwards, he got only IV. And when we did the levels before he got the dose and after he got the dose, the levels are different. So 0.491 is an early morning sample before he gets the daily dose. And then once we continued getting IV from 23rd to 28th of May. The doses varied a little bit, 150 to 200. And obviously, free T4 was not checked. So at this point of time, 26th May, when his free T4 was 0.491, I told them to not keep checking every day. Let's just check after 3. And because he was getting clinically much better. So I said, let's not check every day. Let's just wait for next 3 days on IV. So he got the 200 dose for next 3 days, and this was his last free T4, 29th May. It was 1.14. And so it had improved beautifully. So you can see from 0.1 to 1.14. And of course, TSH doesn't matter because, they were checking it, but you don't have to check TSH. And then 29th May, so he was tolerating, food. He was back to his senses, some delayed speech, but he insisted. He was a laborer. He had no finances. He wanted to go back to his home country. So he left against medical advice. So on discharge, I discharged him. So his weight was about 78. So even if you do 1.6, it comes to about 124. And his PT4 was good. So we discharged him on 150 micrograms. And unfortunately, after that, I have no follow-up because he left the country. So just very quick, salient things about myxedema coma I really want to talk about in terms of management. So again, this is a condition important to know from long-standing hypothyroidism. And what happens suddenly, the body has loss of mechanism to maintain homeostasis. And any cause, very important, any cause of hypothyroidism can lead to myxedema. So the etiology does not matter. The mortality is somewhere as high as 60%. That was earlier. Now, more recently, it's come, to 20-25% because we have, amazing ICU care. And very important to note is, so the coma is actually a misnomer. Most patients are not in coma. So the salient feature is deteriorating mentation. So even our patient, when he came in, he was a little stuporous and it just kept getting worse. So they don't come in coma. And more common in females, more common in elderly, but ours was a male and ours was not elderly. And the other important thing is mostly they come to the ER with altered mental status, like our patient, with hypothermia. The lower the body temperature, the worse is the prognosis. Another important thing is, so normally hypothyroidism has diastolic hypertension. So when you start losing that mechanism, that's actually an impending myxedema coma. So this our patient has hypotension. Again, augmentation could be anything from depressed affect to psychosis and coma, hypoventilation, hypothermia, hypoglycemia, but our patient had hyperglycemia. Again, lab, our patient had all of this, anemia, elevated transaminases, hyponatremia, all of this was there. He had abdominal distension and he was cold, clammy, bradycardic. So he was textbook myxedema coma. Important things, just couple of slides on treatment. So all patients need ICU care. It's very important, especially if you have any patient with cardiac issues like our patient, females, elderly, persistent hypothermia, reduced consciousness, coexisting sepsis. You have to make sure that they're higher mortality. They have to be ventilated. And this is very important. Patients should not receive ventilatory support until their consciousness better. And that didn't happen in our case. As long as his hypoxemia and vitals were stable, they extubated him. Of course, fluid resuscitation, warming, antibiotics for infection, vasopressors, treats the hypoglycemia, treats the hyponatremia. These things are actually very important in myxedema. So, this is where the ICU and endocrinologists have to work together. Now, the most important part is the thyroid hormone therapy. That's the key treatment, very, very important. We'll talk about the doses. Always P4 more than P3. We'll talk about P3. And just remember, anybody with any kind of coexisting, like our patient had cardiac, the hypothyroidism actually it makes the cardiac condition worse. So whatever is it, sepsis, cardiac, liver, hypothyroidism is the main thing over here. So that's why LT4 is very, very important. Going back to the dose, this is ATA recommendation. A loading dose of 200 to 400. This is where you have IV facilities. We didn't have that. So the loading dose is anywhere between 200 to 400. Most people, I would love to hear if you guys have treated anything, but in the US, we used to start with 200. We should never go more than 200. And then, of course, if the patient is older, less weight, history of any CAD, you would do lower dose. And after doing a loading dose, you would do a daily replacement dose of 1.6 times body weight. And since it's IV, that dose is 75% of it is what is IV. And would you start steroids? Yes, you would if you don't do a level. Now talking about P3. So before I come to P3, going back on very, very important take-home point is you can treat myxedema coma purely on clinical suspicion, like when he arrived in the ER, even before your labs come out. Because sometimes that takes time, because that also affects the mortality. And also very important is degree of TSH is not an indicator of severity of hypothyroidism, because TSH is made by the pituitary. So based on how sick the patient is, your TSH value is going to change. So again, do not rely on that, because there are patients, like older patients will not have TSHs like in the 50s, and pan-hypopig will not have high TSH. And we've already talked about this, antibiotics, steroids, and treat all the other parameters. Now, the role of T3, because again, in UAE, we don't have T3 easily available. In the US, we had. Very important to know is that when you have a myxedema coma patient, T4 to T3 is decreased because of the high metabolic state is reduced. So that's the reason some people use T3. So if you use it, when would you use it, and what's the dose? So basically, the dose is typically 25 or 50 micrograms, again, a loading dose. And this is typically, again, given if your patient is not getting better on T4. That's the only indication for you to give LT3. You would not do it routinely. Our patient had a low peak T3, doesn't mean you have to give T3 along with T4. Because higher doses of T3 can act as actually associated with mortality in these patients. So it's very important. There's no data on how long you would continue with T3. They say until a clinical response. So any clinicals which are not improving, you could either increase your T4 dose, or even after increasing T4, if you don't have clinical improvement, like in terms of heart rate, in terms of blood pressure, in terms of mental status, then you could do that. So that's very, very important. And lastly, these are some of the case reports of different regimens used. So there was a case where a study where TSH values were about 80, and they were treated with about 100 micrograms. So not even the loading dose, just 100 daily. Like typically what my patient, we gave 150 daily. And that normalized the free T4 in 4 days. Another case report, they did a dose of 200 every 8 hours. So in the first, as a loading dose, just gave him 1 milligram of euthyrox, and that also significantly improved in 48 hours. So some people have done that. And other people, the other case reports where they've combined, T4 and T3 for 5 days, and that has also improved. So there are many, these are all case reports which has improved. Um, there is actually this last thing I want to talk about is this observational study for how would you calculate the oral dose. So because again, we are talking about a UAE where IV is not easily available, like even in other countries like where we practice in India. So, there was this, it's an observational study, but this is 14 patients. Again, we have very few data on myxedema coma patients because it's a rare condition. This was between 2010 and 2019 to show whether oral dose is effective. So basically, these were 14 patients. Mainly, they were male and they were like 67 years old. 9 out of those had pre-existing hypothyroidism. This was an ICU stay for about 12 days for most people. Most of them were severely sick, so CNS manifestations and in the ICU. And you see most of them, their TSH was anywhere between 67. So they were in 3 categories. No history of coronary artery disease, you give like a full dose of 500 oral. If they had compromised EF, then you would do lower 300. And if there was both CAD and no EF, then you would do 275. So in these, if you base on your patient, so my patient had CAD with a reduced EF. So the starting dose would have been 275. I chose 200. I chose 250. And so in this case, they said, so out of these 14 patients treated like this, 13 patients survived. Only one person died. And that one person who died had a very high score of more than 100. So this basically, this study showed that, a mortality of 7%, which is very low, can be achieved if you give patients oral. So this is again just a case report, but at least we have some data. This is how I based my oral dose. I gave him 200 because he had severely compromised.
Thank you, Doctor.
Yeah.
That's very nice. Because we don't have much time, just one comment or one question. Need more discussion.
I need 3.
But time.
Yes, I didn't forget. Yes.
I didn't forget this
When
one.
to use T3?
Yeah.
Yeah. So basically, you don't use T3 at all. You always use T4 and watch for clinical improvement. In a situation after 48 hours, if you have no improvement in mental status, in the hemodynamic parameters, in the T4 levels, then you decide to do T3 along with the T4, obviously.
Okay.
Yes. You just add. Yes, it's not given from the start at all. The primary treatment is always T4.
Is usually T3 is controversial issues in
Yeah,
hypothyroidism.
yeah.
I saw one debate, 1 hour between 2 faculty, one with, one against in hypothyroidism.
Yeah.
Just any comment?
Anybody would have done anything, I would love to hear
Is this
input.
case? Oh, the email. Below 60, not female.
Yeah.
In summer, not in winter,
Yeah.
Everything.
In peak summer.
I mean, it's very well managed and very good shape. It's wonderful. Yes. So hopefully.
Thank you, Doctor.
Yeah.
Actually, I shouldn't be speak today. My colleague, Dr. Ali Dibiat, he declined 1 hour ago. And his topic was very important because thyroid and hyperthyroidism. So, and just in the lobby, I just have one case last week in my place, and it's opposite to Dr. Case. Plus thyroid storm. So I'm sorry for the slides not very arranged. I just did it very fast. So I will speak on just 5 minutes only, just to fill the gap. So Ali is 40 years old. Guy presented to ER with abdominal pain and mild diarrhea. So the guys in ER did just symptomatic treatment and did the routine lab CBC, creatinine, liver enzyme, and everything was okay. You give him some medication, symptomatic and discharge the patient, and discharge home. Second day, he felt fatigue, palpitation. He went to OBD and he received again symptomatic treatment and discharged home. The same night, he came again. He collapsed at home, agitated, mild, hypotension and palpitation, and our cardiologist saw the patient AF, admitted in the hospital with AF, hypotension, admitted to the CCU, and the ejection fraction was 15%. So AF, heart failure. So they treat cardiology treatment, cardioversion, and withdrawal, all that things. But of course, the routine cardiologist, once they have tachyarrhythmias, they do thyroid function as a routine. And then result come, TSH was suppressed, or maybe another, or missing, and called me in the morning. They say that there is consulting like normal thyroid TSH. Also, by telephone, I say just check T4, TSH receptor antibody, ESR. It could be thyroiditis. I was not in my mind. TSH receptor antibody, and then they called me like 3 p.m. They say T3 and T4 high, but not very high, like just high. As the same thing as in myxedema coma, is not the chemical parameter which say, and the patient have still agitated, pulse rate 165. And then 4 p.m. they called me after some time. They say patient like go to cardiogenic shock. So I ran to the hospital with them just to see cardiogenic shock. The patient, they put him in tropes and everything. So I put him in a score. There is a questionnaire.
BW score.
I was.
Also,
Yeah.
it was there in the
Porch,
the
Waters,
same-
Mosky point scale
same
for
point.
thyroid
I was
exposures,
just
and the cutoff point from 45. I will choose a score. Clara, can we see the online one? It's from 45, it gives the diagnosis thyroid storm. It was 55. I just and then I called the cardiologist. I said to him, "This is thyroid storm, and it suits all criteria." I will show you very fast. Is any chance or no? Shmarut. So anyway, this scale, of course, short time I couldn't put in the system. Temperature of the patient, like every temperature, like 30, 37, but the patient was afebrile. Same was not hypothermic, was not hyperthermic. Can we download? It's okay. No, it's okay, Mustafa. If you cannot, that's fine. Bravo, Mustafa. Yeah, how we can go down? So temperature, he gets 0 because he was tiny. It was not feverish. Can we go scroll down? Or? Yes. CNS, I put him mild agitation, so he takes 10 score. Gastrointestinal, yes, I put 10 because he got moderate diarrhea, jaundice, vomiting, abdominal pain, he was present. So 20. Heartbeats, I gave him 25 because 169. So خلاص 45 now. Again, congestive heart failure, ejection by cardiologist, second ejection fraction 58. So that's done. Precipitating factor for me was not obvious. Precipitating infection, not infection, I don't know. So also precipitating factor. So I say this is thyroid crisis according to this score. So we know the treatment. What is the treatment usually? Therapy to control increase adrenergic tone, beta blocker. So propranolol bulk, but I will say the dose. Therapy to reduce thyroid hormone synthesis, either carbimazole or BTU. I know since we are in medical school, BTU is more faster and all that, but I really afraid from this medication all my life because I see many hepatic decompensation. So I just avoid it. Therapy to reduce the release of thyroid hormone, Legos IV. I found in hospital Legos IV. They bring it after some time, but we found luckily Legos IV. I know our colleague surgeons use it before thyroid surgery. Yes, right? So this make immediate stop of the thyroid. So I add Legos IV, 8 drops every 8 hours. Glucocorticoid, same hydrocortisone 100 every 8 hours. Of course, for peripheral conversion, and also BTU have another advantage than carbimazole for peripheral, but I didn't use. Therapy to reduce enterohepatic recycling thyroid virus is good, so we don't have, and I didn't. This is the usual treatment. What I did, next slide. Yeah, I used propranolol in the start. I used tablet 40 every 6 hours, but I didn't use because patient in cardiogenic shock. So it's contraindicated. So I talked with the cardiologist. I said to him, this is contraindicated. I cannot use beta blocker. So we agreed not to use beta blocker. Of course, carbimazole, I used 20 every 4 hours oral tablet because obviously there is no infusion. And
the levothyroxine, I told them 1 hour after the new mercazole. And I gave hydrocortisone. After sometimes, after sometimes, next day, patient becomes hemodynamically stable. So cardiologist told the registrar, tell me how I want to have LDR because rate limiting for it. So and he put him in drug infusion. Actually, patient stayed. He was intubated, so he stayed one day more, become hemodynamically stable, and the pressure all inotropes withdraw, and patient become extubated. But also, I didn't see the patient because family insists to refer the patient to Rashid Hospital as well. But at least he was in a good condition. I said, let us write a medical report. Because as a doctor endocrinologist, we didn't see this cases much as endocrinologist. So you can imagine the other. So it was like all registrar come, like, it was like evil thyroid stuff as we see in the books. That's my...
Thank you.
We go for last talk. This is JULPHAR presentation. Clara Shaukat, Senior Medical Representative for JULPHAR Cardiac Line, right? So it's yours.
Hello, my dear doctors. Good evening. I will not take much time because we have to catch our dinner. So let me introduce our first star product, Rosalus. It is plain rosuvastatin of JULPHAR. Our concentrations are available in the market, 5, 10, 20 rosuvastatin in the form of Rosalus as a brand name for JULPHAR. Let's first introduce that according to 2015 global death, 70% of the deaths worldwide was due to non-communicable diseases, NCDs. And 45 of these 70% was due to cardiovascular disease. So it represents a lot worldwide. Our first study for rosuvastatin or Rosalus, it's Mercury 1. Mercury measuring effective reductions in cholesterol using rosuvastatin therapy. That's to summarize this study because it's a little bit long. A lot of patients, it was randomized, multicentric, switching study. It's called switching study because we will switch from atorvastatin, simvastatin, pravastatin, all into rosuvastatin, and we will check the efficacy. We selected the patient with hypercholesteremia, established atherosclerotic diseases, and type 2 diabetes. And these patients considering high-risk patients. So some of these patients took atorvastatin 10 mg, atorvastatin 20 mg, simvastatin 20 mg, pravastatin 40, and some took rosuvastatin 10, Rosalus 10, and then remained to Rosalus 10 after 8 weeks. So the first 8 weeks, they took the following active ingredients or statins, and then they shifted to other statins. They shifted to rosuvastatin 10 mg or Rosalus 10 mg. Okay, what we'll find in the first 8 weeks, so we will talk about that arm now. In the first 8 weeks, we found a great reduction in LDL by Rosalus 10, which is -47 between all statins. It's the greatest reduction in LDL by Rosalus 10. What about HDL increase? Because you know that statins has effect for HDL percentage. So Rosalus 10 was the highest increase in HDL percentage. Okay, this is the first 8 weeks. What about at week 16? After other 8 weeks, we found that the people or the patient was taking atorvastatin 10 and shifted to rosuvastatin 10. They found LDL reduction by 86%. So 86% of the patients found more reduction in LDL by rosuvastatin 10. Same for atorvastatin 20. That's why we are saying that Rosalus 10 is equivalent to atorvastatin 20, and Rosalus 20 is equivalent to atorvastatin 10. That's why we are saying that almost the efficacy of Rosalus double the efficacy of atorvastatin in the reduction of LDL and the increase in HDL. Okay, so same for the other groups. So we found as a conclusion, greater percentage of subjects who switched to rosuvastatin or Rosalus at week 8 reached target at week 16. And this is considered to indicate a clinical benefit of treatment with Rosalus. Okay. So we have conclusion that Rosalus is the most lowering LDL statin. Between all statins, we find that rosuvastatin between 5 or 10 mg or Rosalus 5 or 10, we found the highest or greatest reduction in LDL percentage. It reaching 45% LDL percentage. Here, according to the European guidelines, 2016, between all statins, rosuvastatin 40 is the most powerful in the reduction of LDL. And if we find, if we have a look for Rosalus 20, we will find it more powerful than any other statin. And Rosalus 20 is equivalent in this chart to atorvastatin 40. Here, if we find atorvastatin 40, it will be equivalent to Rosalus 20. Double the efficacy. Same slide. So to summarize all for Rosalus, Rosalus as a single therapy, valuable option and the most efficient treatment for a broad spectrum of patients with dyslipidemia. Rosalus, effective in reducing LDL, superior efficacy, the most one effective for reducing LDL across all doses range and the most effective than equivalent and maximum dose of atorvastatin, simvastatin, pravastatin. Rosalus offers consistent improvement in HDL. It's not only lowering the LDL, but also it's increasing or improving the HDL ratio, triglycerides, lipid ratio, and the lipid profile as a whole. Rosalus effective and well-tolerated agent that can produce beneficial changes in atherogenic lipid profile. As we said in the introduction of the study, we selected patients with atherosclerotic diseases till these patients reached the recommended LDL goals. Finally, Rosalus is significantly reducing the risk of cardiovascular disease. Okay, any questions for Rosalus? We are available in most of the pharmacies, most of clinics, Rosalus 5 mg, Rosalus 10, Rosalus 20. Second one, I will talk about our...
Can I ask you?
Yes,
Yes, it is the most effective for reducing the LDL levels, but what about the cardiovascular mortality? Any studies compared to other statins?
Mainly, doctor, yes. We have one study. I will check and return to you back, doctor. I will get your email and send this study to you. Yes, there is one about the mortality between all statins. It's very good in preventing the cardiovascular events or cardiovascular death. That one, doctor, you are asking about.
Statin was more, yes, it is less effective in reducing LDL, but it is more, it has better data for reduction of cardiovascular endpoints.
Yes, yes, doctor. Which is myocardial infarction, stroke, and cardiovascular. Yes, atorvastatin is a little bit more in this preventing cardiovascular event in this property, but we are talking mainly in reducing the lipid profile for the patient or significant reduction in LDL, so it will be for sure Rosalus. If we're gonna talk about preventing cardiovascular events, which is a stroke, myocardial infarction, cardiovascular death, let's see Omigold. Omigold, our superstar prescription-based omega-3, it's a slogan, getting the gold out. One capsule of Omigold, it will inhibit hepatic triglyceride synthesis, decrease VLDL production, and decrease VLDL metabolism. I will not talk more about that. Our Omigold 1 capsule containing more than 90% of this capsule containing EPA and DHA, so it's highly purified omega-3, highly purified prescription-based omega-3. It's not a supplement at all. Containing 460 mg of EPA and 380 DHA. This is its purification process. First of all, it will be crude fish oil. After removal of pesticide, cholesterol, it will be in concentration omega-3 fatty acid 30%. After that, purification step 3, removal of saturated fatty acid till we find the end omega-3 fatty acid concentration 90%. So one capsule is very concentrated omega-3 more than 90% of this capsule containing EPA and DHA highly purified. Okay. After that, Omigold, it's golden add-on therapy in mixed hyperlipidemia. If we compared to use Rosalus only, Rosalus 20, the gray one is Rosalus 20, and the gold one, Rosalus 20 plus Omigold. If we compared between both, you will find that greater reduction in triglycerides and non-HDL. So Omigold is not reducing triglycerides only. It's decreasing or reducing the non-HDL profile as a total, LDL, apolipoprotein, all. So that gold chart showing the highest reduction in triglycerides, 26.3%, compared to Rosalus 20 only. And here for non-HDL as a total profile, it's decreasing by 10.7% comparing to Rosalus 20 only. So the best combination to reduce and the effective reduction for LDL, for triglycerides and non-HDL is rosuvastatin 20 plus Omigold, or Rosalus 20 and Omigold. So it will decrease to greater extent than statin alone. This is our conclusion from our study. Second study, that one, doctor, that you are tackling that point, which is gold long-term protection beyond triglyceride control, which is for 3.5 years time interval. It's decreasing the rate of death, non-fatal myocardial infarction, and stroke. 3 parameters, which is our cardiovascular event endpoints. So for Omigold, we find that it decreases the sudden death by 45%, which is huge percentage for sudden death, 20% for cardiovascular death, which is non-fatal stroke and MI, mortality causes 20%, and cardiovascular death 30%. So this slide or this study showing the prevention from cardiovascular disease by Omigold. Last one, it's a summary. Omigold is a Swiss brand. It's not locally made. It's Swiss brand, prescription-based omega, highly purified. Its concentrations, more than 1 capsule, more than 90% of it containing EPA and DHA by 460 and 380 respectively. Omigold prescription omega-3, complementary mechanism of action and decreasing the lipid profile as a total, not only triglycerides, non-HDL as well. A combination of Omigold and statin decreased triglyceride and non-HDL as a whole. Treatment of Omigold over 3.5 years shown significant reduction in the cardiovascular disease prevention, which is myocardial infarction, stroke, and non-fatal myocardial infarction. Cardiovascular death. Last, Omigold plays a role in modification of lipid and lipoprotein metabolism and possess a lot of properties as shown in the studies. Okay, so last, Omigold, our mega star omega-3 prescription-based omega-3, and by the way, it's covered by all insurance categories, basic, medium, high, all, and it's available in the most of the accounts, most of the pharmacies. It's available.
I checked our omega-3 in pharmacy. We have on code. We haven't.
Sure, doctor. I will pass by you. تمام.
Just one point.
على فكرة أنا رحت وهو قال لي مش
شفتي بقى؟ أنا
Just one point. Starting dose is 2 tablets.
Yes, doctor.
Because I see some prescription one and all this.
One is for prevention or for doctor, maybe the dose is 2 to 4 grams per day to reduce
for all this
triglycerides. Yes.
for essential.
Thank you, doctor.
Just before we close, because we have only 10:30, you have to move, right?
Yeah.
Any question in any of the talks today? I'd like to
دكتور عايزين بس ناخد صورة.
Dr. Khan, any comment? For group foods maybe. Okay.